Hello, everyone. Thank you for joining us today. I will just give us 30 seconds or so here to let everybody join. Okay, we are leveling off here with our folks joining, so I'll get us started. Thank you so much for joining us today. Before we get started with today's webinar, I'd like to acknowledge the land on which Parachute is located. For thousands of years, it has been the traditional territory of the Wendat, the Anishinaabeg, the Haudenosaunee, Métis, and the Mississaugas of the Credit First Nation. Today, this land is still the home to many Indigenous people, and we are grateful to have the opportunity to work on this land. And while we meet today on a virtual platform, we encourage you all to take a moment to acknowledge the importance of the lands which we all call home. Welcome to the third and final event in our 2026 Toxicovigilance Canada Poison Webinar Series. Parachute is pleased to present this webinar in collaboration with the Canadian Association of Poison Centers and Clinical Toxicology and the Toxicovigilance Canada Public Outreach and Communications Working Group. Every year, we explore various topics and areas of expertise related to toxicovigilance, highlighting the amazing work taking place across Canada, from surveillance and detection to public health communications and response. For today's event, we are thrilled to welcome 4 speakers: Paula Migliardi, Dr. Sarah Lesperance, Samantha Lancione, and Colin Steensma, who will be presenting today's webinar, Novel Drug Surveillance Sources and Current Drug Trends. Drug surveillance programs and data sources are an essential component of toxicovigilance. Our speakers today will share about 2 different drug surveillance programs in Canada and let us know how we can stay informed by accessing reports, surveillance data, and drug alerts. Before I introduce the speakers for today, I'd like to start us off with some housekeeping items. Firstly, the webinar today is being recorded. We will have time for questions at the end of the webinar. Please use the Q&A box at the bottom of your screen to ask your question. We will also have folks monitoring the chat for any technical issues, so please put any technical issues in the chat box. And at the end of the webinar today, when you're leaving, you will be prompted to complete a short evaluation that will take 1 or 2 minutes to complete. And your feedback is really valuable to us as we plan future opportunities like this, so please do take a moment to give us your feedback on your way out today. On the agenda today will be presentations from our speakers, followed by a Q&A session. And I'd like to take a moment now to introduce our speakers. Paula Migliardi is the program specialist with Healthy Sexuality and Harm Reduction, Population and Public Health of the Winnipeg Regional Health Authority. Paula has a background in anthropology and has more than 2 decades of experience in collaborating with diverse communities in community-based research and program evaluation. Her main areas of interest include sexuality and sexual health and harm reduction. Paula has been instrumental in the development and implementation of drug tracking services at Street Connections. Dr. Sarah Lesperance is a public health physician who works as a medical officer of health in the areas of healthy sexuality, harm reduction, and substance-related health at both the Manitoba Provincial and Winnipeg Regional Health Authority levels. She approaches her work with a background in equity-focused health policy and a focus on the social determinants of health. In addition to Royal College of Canada specialization in public health and preventative medicine and certification as a Canadian family physician, she has academic and employment history in commerce, social work, mental health counseling, and health policy. Samantha Lancione, a senior analyst, and Colin Steensma, a senior epidemiologist, are with the Office of Drug Research and Surveillance in Health Canada's Controlled Substances and Cannabis branch. With backgrounds in epidemiology, they support high-profile federal initiatives addressing the drug crisis, including the National Wastewater Drug Surveillance Initiative, Canadian Drug and Substance Watch, and supervised consumption sites monitoring. Together, they advance data integration, analysis, reporting, and cross-jurisdictional collaboration to strengthen evidence-based surveillance across Canada. Thank you so much, Paula, Sarah, Samantha, and Colin, for joining us today to present on your work in drug surveillance and current drug trends. I will now pass to Sarah to begin your presentation.
Okay, super. Thanks so much. I'll just get started with my sharing. I guess if we're seeing an echo with you, Sarah, maybe it's the fact that there's two Sarahs on the call and they're hearing us both at the same time. We'll get going here. Just bear with me 1 second. Okay, if I'm doing this right, you should be able to see my screen. I'll just plop it into presenter mode. Is that correct?
We can see your slides. That's perfect. Thank you.
It's moving on me. Okay. Very good. We'll get started, and thanks for that welcome. So in today's presentation, our part of the presentation, at least, we'll be covering three main areas. First, what we're going to look at is what makes illicit substances particularly risky and consider the features of the unregulated drug supply. Second of all, we're going to zoom out to review broader trends in the illicit substance landscape to look at what's emerging, what's changing, and what that means for communities like ours. And third, we're going to focus on our services in Winnipeg, describing the public health response that our team has developed to meet people where they're at and to respond to the local drug supply.
You may notice us using both drug toxicity and drug overdose here today. And although these are similar terms, and there is an important distinction worth naming. Drug toxicity describes harmful physiological effects from substance exposure, especially where harms result from unknown or unexpected contaminants, and not just from how much someone uses. Drug overdose refers to situations where the body is overwhelmed by a substance and immediate medical intervention is needed. Drug overdose may not necessarily be intentional. In public health, we use drug toxicity because it reflects what communities are actually seeing. Unexpected harms driven by an unpredictable, unregulated drug supply. The Canadian Public Health Association uses this framing for the same reason, as it reduces stigma, shifts focus to supply risk, not individual behavior, and aligns with harm reduction values.
Sorry, if I could just jump in. Sorry, Sarah. Your camera's off. I'm not sure if you are.
I can't figure out how to turn it on, actually. It doesn't have the little thing in the corner. Do you have a suggestion? I'm happy to do it. I just don't know.
Perhaps if you're able to navigate to your Zoom window, because you're probably looking at your presenter view. If you're able to navigate to the Zoom window, you should be able to find your camera button there.
Okay.
If not, we can live with
I feel like I will probably screw something up. My apologies. I think I'm just going to continue, okay?
That's perfect. Thank you, Sarah.
Okay, so unlike pharmaceutical drugs with rigorous quality controls, there are no safety standards for illicit drugs. Take cocaine as an example. Production is concentrated in unstable, often rural regions where coca leaves are processed in clandestine labs using gasoline and other chemicals. As these products move through multiple hands across different continents, they're often cut with various additives or fillers, and sometimes using equipment that's contaminated with residue from other potent substances. The economics overall of the illicit market drives suppliers towards easily concealed, potent products with cheaper substitutes wherever possible. And when these international supply chains are disrupted by law enforcement, suppliers quickly replace their seized products with whatever alternatives are available, causing sudden and dangerous changes in local drug supply. The overall reality we see is that the unregulated drug markets are inherently dangerous by design.
So these are some of the main substances categories behind Canada's drug toxicity crisis. Opioids, particularly fentanyl and its analogs, are the primary cause of fatal toxicity. In the first half of 2025, fentanyl was detected in 57% of Canadian opioid deaths. Fentanyl's extreme potency means respiratory depression can be rapid and fatal. Stimulants like methamphetamine and cocaine are also quite prevalent. They may contribute to death alongside opioids, reflecting polysubstance use trends, but also have cardiotoxicity risks themselves, causing heart attacks, strokes, and dangerous arrhythmia. Non-pharmaceutical benzodiazepines like etisulam represent another challenging trend. In 2023, 33% of illicit opioid samples tested in Canada also contain at least one benzodiazepine. Veterinary sedatives like xylazine and medetomidine also play a role. Like benzodiazepines, these animal tranquilizers can't be reversed by naloxone and may cause prolonged deep sedation. The critical issue is that many people don't actually know what they are consuming. Down opioids may contain unexpected sedatives, fake Xanax pills can be laced with potent carfentanil, and baggies bought on the street may look identical, but contain drastically different compounds.
In Manitoba, we're seeing similar patterns. The graph here on the left depicts Manitoba's substance-related fatalities, which are illustrated by the purple bars between 2021 and 25. The line graphs in this chart further highlight how stimulants, which is represented by the blue line, and opioids, which is the turquoise line at the top, intersect and contribute to high rates of fatality trends. Benzodiazepines, which are illustrated in the light green line that you see at the bottom, can also be seen as an emerging and key contributor, starting specifically in 2022 to rise and peaking in early 2024. Illicit overall, what we're seeing is that illicit substance fatalities have been showing a modest decline in recent years in Manitoba. The sustainability, though, of this decline may be questionable because new and unexpected substances are continually emerging on the scene. When you look at the other chart, you can see how naloxone, which is an opiate antidote, is depicted in terms of numbers of distribution by the green bars, which shows that the distribution of our free take-home naloxone kits in Manitoba has been trending upward. And most notably, you can see that change in Winnipeg, jumping from 3,300 kits in the first quarter of 2021 to over 16,000 kits in the final 3 months of 2025.
In public health, we integrate 5 key elements in our response to illicit substance harms. Surveillance and monitoring to understand the local drug supply, harm reduction, a judgmental way or approach of supporting people's wellness in the moment, sexual, transmitted and blood-borne infection prevention, including prevention of HIV, syphilis, Hep C, and other infections, drug fatality prevention, which we address risk through community education and connections to medical and social services. The intersection of homelessness, injection drug use, and HIV affecting our inner city community members remain one of Manitoba's key public health challenges. Because drug-related harms disproportionately affect already underserved communities, public health aims to approach our work through a trauma-informed, anti-racist, and de-stigmatizing lens.
The Street Connections public health team is located in downtown Winnipeg with Monday to Friday walk-in office hours and a mobile van providing services to a set number of inner city stops 6 evenings per week. Our multidisciplinary team includes public health nurses, outreach workers, communicable disease technicians, program specialists, and public health doctors. We provide STBBI blood work and point of care testing, sterile needle and smoking supply distribution, safer sex education and supplies, substance harm reduction education, as well as take-home naloxone kits and training. In 2024, Street Connections launched an in-office drug checking service, and its integration with the rest of our services was intentional. Not only was drug checking requested by community, it also provides a great relationship starter. For example, a person may come in for drug checking and stop to pick up harm reduction supplies and speak to an outreach worker. Then they may see a nurse and get STBVI testing and treatment. And then they may discover links to other services like referrals to social assistance, HIV specialists, or addictions medicine. In this way, drug checking becomes one part of the overall Street Connections harm reduction experience.
In our first 18 months of drug checking services, we engaged in over 310 testing encounters and completed more than 420 individual substance checks. Each visit may involve checking one or multiple substances. And the program serves both new or returning clients. All services are free, anonymous, voluntary, and confidential. And of course, they are also legal under Health Canada exemption. Although drug checking may provide people with information about their drugs, it is not a guarantee of safety. We only test a small sample, and the rest of the batch may vary. Drug checking does not eliminate other harm reduction approaches like consuming substance around others, having naloxone available, using only small amounts, or and accessing emergency services. Our approach is grounded in harm reduction principles, meeting people where they are at, to understand the reasons for substance use, and not assuming that abstinence or treatment is the first thing that everyone wants or needs.
So drug checking begins when a client provides a small sample of their substance for testing. After gaining informed consent and explaining the process, then Street Connections staff will test the sample using Fourier transform infrared spectrometry and immunoassay test strips. Trained drug checkers then interpret results with the client in an educational and interactive conversation focused on harm reduction and connections to services and supports. This isn't just about handing over test results. It's a collaborative discussion about what was found and what it means for an individual. For unexpected or concerning findings, samples can be sent for confirmatory testing, which validates our results and adds to national data collection. These two testing modalities, fighter and immunoassay test strips, are a standard combination in most community drug checking services across the country. The benefit of the fighter is that it is rapid and it can identify multiple substances. However, it can only detect those present at 5 to 10% or higher. For potent substances like fentanyl, which can be lethal at very small doses, this limitation is significant. That's why immunoassay test strips are also used, because these strips can detect fentanyl, benzodiazepines, and other substances at very low concentrations. The two technologies together give far better information than either would alone.
The Street Connections drug checking data illustrate patterns in Winnipeg drug supply. Interestingly, stimulants and psychedelics are the most common samples that people bring for checking. We also frequently test opioids in pills or powder form, and often detect fentanyl in these samples. We're seeing a variety of non-pharmaceutical benzodiazepine, as well as unexpected adulterants and cutting agents. Emerging detections are particularly concerning, especially medetomidine, a strong veterinary sedative, and novel fentanyl analogs like parafluorofentanyl, and of course polysubstance samples with 3 or more components. Results of the testing are summarized in our quarterly reports that are available in the Street Connections page.
The medetomidine example illustrates our community alerting response process. Earlier on this year in 2026, we began detecting medetomidine, a potent animal tranquilizer, in increasing numbers of our opioid samples that we tested. subsequently confirmed at concentrations of 3.2 and 5.5% in tablets and powders circulating locally. These levels of medetomidine pose risks of complex overdoses and severe withdrawal. Our initial response was to post an immediate community alert, which is a rapid email notification to service providers and community networks. And we also created an accessible palm card, which were used for easy ground level sharing of information and casual conversations. In addition, we reached out to local emergency response teams and addiction specialists and collaborated on a community alert notice, which was distributed broadly across the province. And furthermore, Street Connections and other Winnipeg drug checking teams launched a new medetomidine test strip pilot just this year. These strips detect medetomidine at very low concentrations and have significantly enhanced our local level detection capacity. This is really drug checking in action. Detect, alert, collaborate, and then respond.
So our fall 2025 evaluation outlined how drug checking influences behavior. Service users told us test results have helped them assess supplier reliability and make informed decisions about their use. When unexpected substances were detected, some choose not to consume them, others modify their patterns using smaller amounts or changing from injection to smoking or visiting consumption services. Importantly, people value the service even when the results confirm their expectations. The verification process itself was reassuring, and they value the interaction with the knowledgeable and non-judgmental staff. The evaluation also showed that some people were uncertain about the service, afraid that they might be arrested, that drugs will be taken from them, or that the police will be called. Given how extensively people who use drugs are criminalized, these concerns make complete sense. These findings shifted our approach so that we actively mention and explain drug checking services and reassure clients about confidentiality, legality, and safety of the environment.
At broader levels, drug checking is also embedded in partnerships of information sharing and supports. We learn from each other, and regular interactions occur between Health Canada, Drug Analysis Service, National Wastewater Surveillance teams, and the Public Health Agency of Canada, as well as national drug checking networks and epidemiological teams. We gain skill and insight by combining these high-level surveillance trends with what we're seeing at the frontline community. Drug checking also remains really indebted to our regional and provincial partnerships and to the pioneering work of and the generous mentorship of the BC Centre on Substance Use, as well as Toronto's drug checking services, who have paved the way for drug checking systems across Canada. The essential point here is that drug checking is not a solitary activity. Communities of practice directly shape and enhance the frontline services we provide.
So as we close, it is important to frame that what we are really talking about here. Drug harms aren't simply about drugs themselves. They are shaped by the structural, social, and political determinants of substance harms. With this perspective, it is easy to see how drug toxicity can be shaped by unpredictable nature of an unregulated supply and how some populations may be more affected than others. It is also more clear why Canada's drug supply is complex and constantly changing, and why coordinated responses are challenging. Fortunately, drug checking provides real-time surveillance and allows for a local rapid response. Given what we know about upstream factors, it is apparent that drug checking is most effective when integrated with comprehensive harm reduction supports. And finally, we understand how important, how much information saves lives. It allows informed decision making and provides community-level protection. When it comes to drug checking in a world of increasingly toxic substances, our work is enhanced by seeing that drug harms are shaped by forces far broader than drugs themselves.
Thanks so much for your attention to our presentation today and your interest. We look forward to hearing your comments and responding to your questions later. With that, I'm going to stop sharing my screen.
Perfect.
And hand it back to you, Sarah.
Thank you so much, Paula and Sarah, for that really interesting and informative presentation. And I'll welcome our colleagues from the National Wastewater Drug Surveillance Dashboard, Samantha Lancione and Colin Steensma, to share their screen and take it away. We can see your slides. That's perfect. Thank you.
Thank you so much, Sarah, and hello, everyone. Colin and I are very pleased to have the opportunity to join you today. And since we don't have that much time, I'll just jump right into our presentation. So Health Canada is continuing to strengthen its surveillance activities to respond to the drug crisis, which continues to have profound impacts on communities across Canada. And one of the initiatives supporting this work and the focus of today's discussion is Health Canada's National Wastewater Drug Surveillance Initiative. So our initiative analyzes wastewater samples that our partners collect nationally to screen for the presence of drugs and drug metabolites across Canada. The NWDS initiative provides timely data on new and emerging psychoactive substances with a focus on unknown substances that may become substances of concern at a later time. So the NWDS provides evidence to support policies, programs, and interventions at the community, regional, and federal levels, as well as identifies current drug trends and can provide unbiased insights into the types of drugs being used and that are circulating across different communities in Canada. Next slide, please. So Health Canada is employing a qualitative approach, which means that we do not quantify the amount of substance in the sample. The qualitative approach screens for the presence of drug metabolites, which occur when a drug is chemically modified by the body, either during or after use, as well as drugs that may be found in the sewer system, whether by consumption or other means like being illegally dumped. Next slide, please. And really, the main reason for us taking a qualitative approach is with the ever evolving illegal drug market, it is important to be aware of as many new substances of concern as possible. So taking this qualitative approach enables us to screen for a much longer list of substances over a quantitative approach. And so one of the main strengths of our program is that we're able to screen for the presence of over 550 substances at a faster processing time and at a lower cost compared to other wastewater programs. And this is what allows our collaborators to get access to high quality data in a timely manner. Next slide, please. So this slide shows our sample journey, which really tracks the sample from collection all the way up to report generation. So influent wastewater samples are collected by our partners and shipped twice per month, and the collection schedules really depends on the capacity of our partners. Samples are then sent to our labs for pre-processing and then to our internal labs for analysis by mass spectrometry to identify the drugs present on our screening list. This data is then shared with our chemistry and data team who processes the data to determine whether the substances are controlled and to classify the substances into the appropriate pharmacological and chemical classes. Once the data is analyzed, we send this data back to our collaborator within a 6 to 8 week delay, as well as an analyzable data set that they can use in however way that they wish. So this data is then at the last step aggregated at the provincial and territorial level and included in the Canadian Drug and Substance Watch and our National Wastewater Drug Surveillance Dashboard that we will be speaking about more today and giving a little demo. So I will pass it over to Colin to start the demo.
Thanks, Samantha. So in just a second, we're going to dive right in and see how you can get information on new and emerging psychoactive substances detected in the wastewater by giving you a walkthrough of our NWDS dashboard. And we're going to do that today with an eye given the parachute community to substances of concern from a toxicology perspective. So there's a QR code here you can scan if you want to follow along. I believe we can maybe even post the link in the chat. But just first, a very quick word on how we chose these substances. So today we're going to take a look at three substances: xylazine, metragynine, and fluorofentanyl. And the way we went about doing this was we looked at substances that have been identified by toxicologists as either being detected in biological samples of fatal overdoses in the most recent year of data from the US Drug Enforcement Agency Toxicology Testing Program, or more generally were recommended for screening by toxicologists. In this case, we're using the Center for Forensic Science Research and Education's scope recommendations. And we provided links here to it if you're interested in learning more about that. So these substances that we chose today were either demonstrated in these data sets to have high numbers of fatal overdoses and or they showed up consistently across quarterly reports. So if we can now just go and open the dashboard. Okay, so we can see here right away that there's 4 tabs: overview metabolites, fentanyl and fentanyl analogs, and understanding the data. So I'll take us through what each of these tabs can show us in terms of our substances of interest. So just beginning with this overview tab, I'll point out a few of the key features. So this key highlights section just gives some very high level context on the number of and type of substances detected, as well as coverage information. So, very important, the number of provinces and territories covered. You'll see which ones those are shortly. And just to mention that currently our reporting period is January 2023 to July 2025, but we will be updating with 3 additional months of data in the next couple of weeks. Then we go into the more interactive portion of the page. So here we can look at overall distribution of substances with a map that are detected in the wastewater by time period geography. We'll be coming back to that map in a second. Also below that, we can the user can take a look at what's the overall distribution of substances by pharmacological class, and then the most often identified substances. So we end this page with this table. So here's where we can actually query individual substances that have been found in our screening to date. So we're going to start with an example of xylazine. So many of you may be familiar with this, but xylazine is a veterinary tranquilizer that's used on animals for sedation. That's its primary purpose and has been showing up more frequently over the last years in the illegal drug supply. So xylazine can decrease bodily functions such as heart rate, breathing, and blood pressure. And just to mention, in addition to the data sources I mentioned, we do also know from Canadian coroner and medical examiner data that there has been a marked increase in apparent xylazine toxicity deaths both in 2023 and 2024. So as we see, if we do type xylazine into our search box for the table, we do see that there have been 17 identifications that have been made. And if we divide this number by the total number of samples analyzed, we get this detection percentage of 7.1%. So total number of samples analyzed simply means the number of reporting sites times the number of months of data. Okay, so what if we want to see where these detections are being found in Canada? So to do this, we can move back up to our map. And just before we enter in our substance, you can just see here overall, get a sense of the 7 provinces and territories where we currently have reporting, although we'll talk about that a bit more in the discussion. We are working to increase participating sites. If we now select our substance, we can either do that by choosing the pharmacological class or directly the substance. We did see in the table that xylazine is in the sedative hypnotic pharmacological class, so we can do it that way. And what we see here, first of all, for our entire reporting period, we do see detections of xylazine being found across our different reporting jurisdictions in Canada. We can also take a look at the most current reporting period. So in this case, that would be from January to July of 2025. And again, we see, first of all, we can just point out that currently, but this will be changing. Currently, we have 4 provinces and territories, and we see that in this case, 3 of those 4 jurisdictions continue to detect xylazine. Okay, we're going to do one more example on this page. We're going to look now at substance metragenine, which is classified as an opioid. So we'll just go down to the table first. So metragenine is classified as an opioid and is also one of the main psychoactive elements in the drug known as kratom. So while kratom is not a controlled substance in Canada, it is not authorized for human consumption and has been linked to adverse effects, including nausea, vomiting, and liver toxicity. Okay, so this time when we enter metragenine, we actually see that there's 2 different entries. So just wanted to explain this a bit. And this information is also included in the notes for table 1. You'll see below the table. So Samantha mentioned metabolites. I'm going to come back to that on the metabolites tab. But just to mention here that what we're seeing is we do on this page group together the parent substance, or what is considered the original substance, with the metabolites are grouped with the parent substance. Sorry. However, there are certain substances that can be both metabolites and parent substances. So that's what we're seeing here with this 7-hydroxymetragenine. Okay, so we see that there are 9 identifications of metragenine, 2 for the 7-hydroxymetragenine. We can again go back up and see where we can find that these substances have been detected in Canada once again. And what we do see in the map is 4 of the 7 reporting provinces and territories in the first part of 2025. I'm sorry, 4 of the 7 reporting provinces and territories do show this detection, and more recently, in the 2025 data, 2 of the 4 provinces and territories show metragenine being detected in the wastewater. Okay, so we're going to move over now to the metabolite tab. So just a quick recap of what do we mean by metabolites. So metabolites are byproducts that are formed when a drug is consumed and broken down by the body. And they are important to monitor in wastewater since they may provide us with more certainty as to whether the substance we detect in wastewater was actually consumed versus, for instance, being dumped directly in the water. So again, as I just mentioned, a substance can be a metabolite, a parent substance, or both. So we get a bit of a breakdown of that by pharmacological class here in this graph. And we can see, for instance, that synthetic cannabinoids tend to be detecting, we tend to detect a larger proportion of metabolites for that class in our wastewater reporting. So, it provides some important context for the following information. So in this next graph, basically, we know that there can be more than one metabolite associated with each drug. And so we have added this, what we call a tree map, to help us make a bit more sense of these associations. So here, for instance, if we were to choose the stimulant pharmacological class, we would see with these dark boxes, for instance, these are all the metabolites for cocaine. So we can see what are the various metabolites that we have been detecting for cocaine use. And the size of the box gives us a sense of how many identifications we have been reporting. And yeah, as you've seen, you can roll over and get a bit more information on that, including the full name. So if we wanted to revisit our xylazine example, we can go into the sedative class. And we'll see here that we do indeed find a metabolite called hydroxyxylazine for xylazine in our wastewater detection, and it has been detected 7 times so far. Okay, so our final stop for the data visualization portion of the dashboard is our fentanyl and fentanyl analogs tab. So, we heard in the previous presentation, and I think most people on the line are aware that these substances are potent synthetic opioids that play a central role in the ongoing overdose crisis. So we have added a dedicated section to explore these detections. And again, very similar to the overview page, we focused on this using a map visualization to see where we found detections in our reporting provinces and territories. So as you can see, we've detected quite a number of fentanyl analogs. We're going to focus in right now on fluorofentanyl, which is a grouping of fentanyl analogs that was identified in our toxicology reference sources as a grouping of concern. So we see here that we find it in each of our provinces and territories for the overall time period. And again, if we wanted to look at the most recent time period, we see 3 of the 4 jurisdictions showing detections. And then just finally, I just want to point out our Understanding the Data tab. So this is really there to just explain all the details about our data. This includes definitions for key terms. You can learn more about the details of how the samples are collected, processed, and reported. Yeah, and so I think that finishes our very quick overview of the dashboard. Just wanted to mention too, and this is also on the Understanding the Data page, some of the important limitations to be aware of. So this is in terms of the testing method. This is a method that we use to detect NPS, new and emerging psychoactive substances at low concentrations. And as such, the reporting criteria are intentionally broad. So the results should be considered as indicative rather than definitive. Confirmatory testing using validated methods is recommended for any critical decision making. And as we'll talk about more, obviously, it should not be seen as the only piece of information. It has to be taken into context with other sources, including, as we heard in the previous presentation, drug checking. There's also drug seizure data. There's a number of different sources that we can use to triangulate and better understand the local and regional situation. Also, just to mention that our program coverage, in terms of our program coverage, the number of municipalities does vary between provinces and territories, and the number of sites can vary from month to month. As the drugs identified do not represent all of Canada, we should interpret any trends with caution. And just with our examples today, we did use primarily US reference sources, as there's very little currently in terms of very specific, especially new and emerging substances and their specific toxicity. So that is why we use those examples. But we're definitely looking to see how we can build in the Canadian perspective. And yeah, we talk about that actually a bit here in terms of our next steps. We're really trying to work with our colleagues in toxicovigilance to see how we can do that, and especially with the Canadian specific lens.
Yes, and just to finish off in terms of the continuing the expansion of our initiative. So, as Colin mentioned, the data in the dashboard is up to July 2025 for right now, but there is an expected update in the next few weeks. But just to give you all an idea of the more up-to-date numbers, so as of March 2026, there are currently 45 wastewater collection sites across all 11 or 11 provinces and territories that are part of the initiative. And as the initiative continues to expand, of course, the dashboard will continuously update and have a more representative picture of what's going on in Canada. And really, Health Canada is continuing to explore opportunities to triangulate wastewater substance detections with other data sources, including our work on the Canadian Drug and Substance Watch, or Drug Watch for short, which is our other dashboard, public dashboard. And that's it for today. That's just our email address at the end. Thank you all so much for listening.
That's fantastic. Thank you very much, Samantha and Colin. That was another excellent and informative presentation about drug surveillance. I will welcome all of those who will be participating in our Q&A to come on camera. And I'll just get my screen up here. Okay. Perfect. And we have a couple of folks, I believe, joining us here that didn't present, but that will be chiming in for the Q&A. So I'd love to welcome those additional members to introduce themselves. We have Pavitra and Andrew. Andrew, do you want to kick us off with just a quick introduction?
Certainly, thank you. Hi, everyone. My name is Andrew Ward. I'm colleagues with Sarah and Paula, and I'm the manager of the Street Connections program here with Winnipeg Regional Health Authority, and I basically oversee the day-to-day operations of the van and the communicable disease technicians, outreach workers, and a select number of public health nurses.
Thank you, Andrew. And Pavitra?
Hi, everyone. I work on the same team as Colin and Sam. I'm a chemist, and I'm here to answer any chemistry questions you may have.
That's fantastic. Thank you both for joining us. So we do have a couple questions coming in here. I want to just start with this one because I think, Colin, you actually responded to this just at the end of the presentation. But just for clarity's sake, we had a question for the wastewater monitoring. Have attempts been made to correlate test results from clinical broad spectrum urine drug testing?
No, the short answer is no. Again, like as I mentioned, we are really exploring, different data sources. Just quickly mention for Canadian Drug and Substance Watch, what we've started out with is trying to correlate with our colleagues in the DAS Drug Analysis Service with their drug seizures. As well as we have a project where we're looking at web monitoring. So we're monitoring specific drug use forums online to see mentions of new and emerging substances. So that's sort of where we've started out. And as I mentioned, we're trying to talk to we are talking with our toxicovigilance colleagues. More from a perspective of, we know that they are monitoring certain substances, including new and emerging psychoactive substances, from a toxicology perspective here in Canada. So we're trying to work with them to see what could be possible in terms of incorporating that lens into our reporting. But no, specifically with the urine testing, we don't have anything currently.
Thanks, Colin. And just noting from our colleague Curtis Olashuk that Curtis will be happy to connect you to the clinical labs through the Toxicology Laboratory Response Network. So that's fantastic. Okay. We had another question for the wastewater team, wondering why some provinces are shown as NA on the map. For example, the Atlantic region. Is this because they're not part of the database or there's insufficient data?
I can answer that one. So there's a bit of delay between the dashboard being updated and our engagement efforts. So really the initiative changes almost daily in terms of how many extra participating municipalities we have, kind of the lag getting them on board to collecting samples. So they we do have coverage across all like 11 provinces and territories. So it should reflect a bit more of the current situation in the next update on the dashboard in the next few weeks.
Thanks, Samantha. Okay, I'll open this question up to everyone, and maybe I'll go first to our Street Connections team. Everybody here today is working within the reality of what data are available and what systems are in place in Canada. Can you speak to some of the challenges you face, and what are the main roadblocks to better coordinating timely toxicology data in response to the evolving drug market?
I can speak to that. Thanks for the question. I think really taking the perspective from which we work in Winnipeg, one of the main sort of barriers we have is just in sort of creating those internal communication networks, even within our province among those that do drug checking. We definitely look to some of our colleagues in BC for an exemplary model in terms of how you can actually bring all of the findings from your multiple drug checking sites into one main dashboard and have an easy point to reference and review and get a good idea of the trends. I think that some of the other things that limit our ability to collect information is just the number of bodies that come through the door. We try to make a very welcoming environment and to do some of the educational work that Paula had mentioned around clarifying that this is a safe and a legal service in order to increase that sense of comfort and perhaps increase greater numbers of results that can help to give us a picture of what's going on. But the truth of it all is that really the results that we share are the results from folks who did take the step to come in. And so you realize that you're also sampling from a somewhat selective group. And so those are some of the things we're thinking about how we might enhance our reach.
Thanks, Sarah. Yeah, it's an interesting challenge. Is there anyone else from the Street Connections team that'd like to put a word on that before I go to the wastewater team? No? Okay, over to the wastewater team. I'm just reminding you the question. Can you speak to some of the challenges that you face in terms of the data that's available, and what are your main roadblocks to better coordinating timely toxicology data in response to the revolving drug market?
I can start, but I definitely hope my team can also contribute, because everyone has a specific thing in mind, I'm sure, in our team. I would say from the data perspective, I think it's I think first of all, wastewater monitoring in the terms of substance use environment. I think a lot of people developed a perception of that work around, during the pandemic and with infectious disease work. And it is a different situation where we have to be very careful not to be stigmatizing communities, and that is why we don't have community-specific information on our tool. Having said that, we do work directly with those communities to provide them tailored reporting on a monthly basis, and we're looking to see how we can do that in a more fulsome way as well, maybe with annual reports. So that's definitely one limitation. And yeah, it's just in general like a very new field. So just understanding like what are the limitations, what kind of absorption are we getting of substances in the wastewater? We are trying to get at that a little bit with some academic partners who do some of this work more from an environmental health perspective. But we do know like this is really still very much a learning experience for us, and so that is also a challenge.
Thanks, Colin. Samantha or Pavitra, did you want to chime in on that piece?
Just seconding what Colin said, really being on the engagement front and understanding the sensitivity around this data and understanding people's hesitation about just further understanding the drug crisis in their regions has been very eye-opening as compared to, like Colin said previously, where wastewater had more of a popularity with COVID, with the pandemic. It was more open to sharing location-specific data as compared to this kind of data.
Thanks, Samantha. We have just a clarification question from one of our attendees. They said that they're sorry if they missed this. How frequent is the water sampled for the National Wastewater Dashboard? And is it regular intervals at the same sites across Canada?
Yeah, I can answer that. So it really depends on capacity, but really our gold standard is sampling 3 times per week. And it's a very small volume, but we usually try to leverage what's already being done at the site, whether if they're already participating in other wastewater programs or for quality control. We really require a very small volume. And yes, it is monthly. So it continues monthly across the sites. And to answer the part about the same sites, well, as more on board, it'll obviously vary from month to month, but it is the same sites across the board. Yes.
Thanks, Samantha. Okay, another question that I'll open up to all of our speakers here. Looking ahead, what opportunities and future directions do you see for advancing drug surveillance in Canada? And maybe I'll go again to our Street Connections team to kick us off.
It's a good question. I think one of the things that is most challenging around thinking about ways that we can enhance drug surveillance is kind of addressing some of the things that we've all alluded to and spoken to so far. And that's really this sense of sensitivity and concern that is associated with this kind of information collection. I think, recognizing the risks and potential harms, as you've said, with the wastewater team, to communities who may not necessarily want that information posted or shared around things that have been located in their area, at the risk of the stigma being attached to that. I think is one of the main things that has that potential to delay some of the partnerships, some of the ways of engaging, some of the ways that sharing about information, and actually just talking about it frankly, rather than sort of being in the situation of often having to defend this sort of research and this look into this work as being, you always have the contractors, you have the yay and the nay, and you often find yourself in the middle of that when you're doing this work, which sometimes closes doors for us to have dialogue and doors for us to actually think constructively in larger groups around what we really want to do and how we want to respond to this crisis across our country and our provinces.
Thanks, Sarah. And on the wastewater team, would you like to chime in on this question? What opportunities and future directions do you see for advancing drug surveillance in Canada?
Sure, yeah. So, I think we already touched on like the trying to triangulate with different data sources. There's so much to learn there still, and it's really challenging work that we're very happy to be able to kind of take on. So just getting more of a sense of how different data sources. We kind of went into it naively thinking they were all going to kind of line up and tell us sort of the same story, and that's not the case. They tell us actually very different things, but that's actually interesting in and of itself. So we're still trying to make better sense of that. And I guess I would also mention that I would actually just also related to our other presenters, I would also just want to give a shout out to the CCSA, Canadian Centre for Substance Use, because they are working on a project to see how, with some drug checking organizations, to see how we can harmonize that data and that reporting across Canada. It is very challenging, as we heard in the other presentation, to different sites can be using different technology, different approaches. So I'm very excited to see how that turns out, because I think that would be fantastic to see what can be done with that.
Thanks very much, Colin. And we are at time here. I have, if folks would afford us 1 minute, I have just one last question I'd like to ask the wastewater team. What channels of communication are in place for alerting, and what collaborators are involved in alerting the community?
For our initiative, we really work directly with the communities in returning the data reports back to them, the monthly data reports back to them. In terms of alerting, we provide a screening list to tell them if there's any new substances that have been identified in their areas. But in terms of more general or overall alerting, we do have the public dashboards. There's no alert per se, but we do often update them. So I would just direct folks to go to those public dashboards to see what's new. We don't have like an official alert system in terms of our wastewater data.
Thank you so much, Samantha. And with that, I think I will close us out for today. Thank you so much to all those who joined us today. And just a quick reminder, please do take a moment to fill out that evaluation survey on your way out. Thank you so much to all of our speakers, Colin, Samantha, Paula, Sarah, Andrew, and Pavitra. Have a wonderful day, everybody.
Thanks, everyone.
Thank
Bye-bye.
you.